This meeting is being recorded.
Okay, so welcome and thank you for joining us today for the meeting of the New York City Health and Hospitals Board of Directors. Today's meeting is officially called to order. Please note for the record that Matthew Ziegler is representing Dr. Mitchell Katz and Karen San-Hilaire is representing Gary Jenkins, both in a voting capacity. Note also that Frida Wang is participating in listening capacity only. Next on the agenda is the adoption of the minutes for the board meeting held July 28th, 2022. Are there any questions, comments, or suggested changes? Can I hear a motion to accept the minutes? So I'm going to go through the list quickly. Dr. William Sison?
Yes.
Matthew Ziegler?
Yes.
Patricia Martone?
Yes.
Michael McRae?
Yes.
Karen San-Hilaire?
Yes.
Robert Nolan?
Yes.
Ernesto Peña Mora?
Yes.
Sally Hernandez Piñero?
Yes.
Anita Kawatra?
Yes.
And Jose Pagan, yes. So minutes approved. So during the executive session, the board received and approved oral and written governing body submissions from NYC H&H Woodhull. The board also received and approved the 2021 Performance Improvement Plan and Evaluation. This is a written submission from Cumberland Diagnostic and Treatment Center, Gotham and Rehab Center. The board also received and approved semi-annual governing body reports, written submissions from NYC Health and Hospitals Kohler and Gouverneur Nursing and Rehabilitation Center. So let me move on now. Thank you, Ms. Hernandez Piñero, for representing the board at the Joint Commission Leadership Exit Session on September 9th at Metropolitan. Would you like to provide any feedback from the visit?
It was so long ago. I'm going to search my mind. I think overall the findings were very positive. I think probably the one sticking point behavioral health issues. You recall there were some behavioral health issues at Metropolitan, and so that appeared that would be an issue. But they were extremely impressed by the deep community penetration of Metropolitan, how deeply they immersed themselves with the community. Overall, the comments were positive.
That's always great to hear. Thank you so much. So I would like to also note that Ms. Lowe represented the board at the Joint Commission Leadership Exit Session on September 16th at Harlem Hospital. So of course, thank you to her for being part of the Joint Commission Leadership Exit Session. Let me move on to Vendex approval. Since we began the process of approving contracts prior to Vendex approvals, there are 15 items on today's agenda requiring Vendex approval, of which 13 have that approval. There are 2 items from previous board meetings pending Vendex approval. Since we last met, 1 approval was received. We will continue to notify the board as outstanding Vendex approvals are received. So let me move on now to, in terms of the President's report, the President's report was emailed to you and included in the materials. Know that Dr. Katz is in Washington, D.C., representing H&H in a meeting at the White House. So let us know if you have any questions, and we will coordinate a response once you go through this report. So let me move on then to resolutions. So I'm gonna item number 2 in the agenda. We're gonna move that for later in the meeting. So let me begin with item number 3. And let me read the resolution. It's authorizing New York City Health and Hospitals Corporation, the system, to stand by contracts with the following 7 firms: MedRight LLC, Rapid Reliable Testing LLC, Premier Assist, the Daybreak Health Group Inc., Somos Healthcare Providers Inc., Fulgent Genetics Inc., and Executive Medical Services. These are the vendors, to provide infectious disease mobile response services when necessary as directed by the system's president, with each contract to have a 2-year term with 2 6-month renewal options, and with a set of contracts not having a pre-established not to exceed amount. And this was presented to the Medical and Professional Affairs Committee on 9/12/2022.
Right. Thank you, Dr. Pagan. So to get started here, I want to give a little bit of a background about our mobile efforts for infectious diseases over the last 2.5 years. So starting 2.5 years ago, we became the first city in the country to have a mobile COVID testing fleet. It became so effective, we went from 8 units to 10 to over 100. That worked so well in being able to bring testing to every community across New York City that we then made a mobile vaccine fleet for COVID. Brought that to NYCHA Developments, we brought it across New York City working with community partners, and it was so effective that we then built out other types of mobile operations, including what I'm going to be talking about in my next presentation, our current mobile test to treat operation. But one of the applications of this was that when monkeypox, or MPV, came about and was an emergency in New York City, we were able to bring to bear all of our experiences using a mobile fleet. And on July 29th of this year, we performed an emergency procurement for a mobile response to MPV, knowing over the last 2.5 years the effectiveness of mobile units. We wanted to apply them to the emergency that was MPV at that time. In parallel with that, is what I bring to you today. We sought to develop a proposal for developing more longitudinal contracts that would go beyond the 2-month emergency on July 29th of this year. To go into some details here, we base this as we have with other contracts for mobile units on a per team per day basis for a pricing structure. For ancillary costs, we've learned enough about this at this point that we can manage this in-house. So the vendors in this proposal will be managed in the Office of Ambulatory Care, my office, with a deep partnership with laboratory operations and medical and professional affairs with Dr. Michelle Allen, our Chief Medical Officer for the system. So if we go to the next slide here. So the scope of this, and this is another lesson learned, is our scope is for infectious disease mobile response services. We didn't want to restrict this to just COVID or just MPV, because we've learned over the last 2.5 years that a variety of urgent situations can arise that are infectious diseases. So we want to make sure this is broad enough to cover us for whatever happens next. So in terms of justification, I gave the general backdrop to why we think mobile units are important and why they've really been a cornerstone of our approach with COVID in a variety of ways over the last 2.5 years and already with MPV. And the purpose of this would be to mitigate the spread of whatever another infectious disease would be, or what a current infectious disease might be, such as MPV in New York City. So we're seeking vendors that can do testing, treatment, vaccines, which you'd do for any infectious disease, and improving capabilities to be successful in these areas. So if we go to the next slide. So the way our RFP worked here, and I'll be brief here, is we had minimum criteria of 5 years in business, having performed similar work, and having a technological infrastructure to support the work. Our substantive criteria were 35% relevant experience, 35% thoroughness of plan, 20% cost, and 10% MWBE. On the right-hand side, you can see our evaluation committee. The next slide is our overview of procurement. So on August 10th, the RFP posted to the city record, and then on August 30th, the evaluation committee completed scoring of the proposals, and the top 7 firms were selected. So in the next slide, I'll show you the 7 firms, and I'll show you I show you here the MWBE goal for each. The upshot of among the 7, there is at least a 30% MWBE goal for each. However, for affiliated physicians, it's higher, 35%, and for SOMOS, it's 85%. Next slide, please. So in terms of the request here, our request is to seek approval to award contracts for these 7 firms to provide mobile infectious disease services with a contract term of 2 years and 2 6-month renewals at the discretion of New York City Health and Hospitals. Expected start date would be October of 2022. List the 7 firms here, and the way the process would work is the president and CEO of New York City Health and Hospitals would be able to activate the agreement with emergency authorization. OMB would be informed prior to any activity taking place, and then the board would be notified of any activations, of course, as always. Clinical input will be sought by my office, Ambulatory Care, and Medical and Professional Affairs. Well, we are in lockstep for things like this throughout. And the estimated cost for these services would be up to $59.49 million for the potential 3-year contract. And that reflects an estimated cost to activate 20 mobile teams, which is how we've started in the past for similar activities. 7 days per week for 4 months per year, each year, over the possible 3 years of the contract. With that, happy to answer any questions.
Thank you. Any questions for
Slowing
us?
down, Ted.
He's not speaking as fast, huh?
Speaking as fast.
Something is going on. You're not speaking fast.
Fenioski Peñamora, go ahead.
Yeah, Penny.
I have a question. Again, as always, you know that you are my idol. You are your number 1 fan. Now that you have this contract, what will happen to the COVID contract that we approved like a couple of months ago? Because this is an umbrella. So do we need to keep both, or you are planning to sunset that one and then only have this one?
Great question. So this would be an umbrella. Actually, the next presentation is the future of where we seek to go for COVID, which really is in the direction of mobile test to treat. Moving forward, I think that's, as I'll tell you more about, that's I think the most effective way to address COVID. But that will be sort of the specific COVID-based contract, and this is intended to be an umbrella to cover anything, which could be COVID, but more likely other things like MPV or other infectious issues.
And we approved one for emergency of COVID, if I remember correctly. So will that contract still be active, or that will be sunset?
So the COVID, right now, the COVID mobile units, we'd seek to fold them into, which is the next, the next contract structure. Then moving forward, we would have a test to treat contract structure. It's a little bit more specific, but that's okay because with COVID, that really is the direction I think we need to go in.
So you will keep that contract. I'm trying to understand if that contract will be
We'll be separate.
will be and will
Separate.
continue.
Yep. But this to be, you're right, that this does cover any infectious disease. So anything on top of what I'm about to tell you about would be covered by this umbrella, which would include COVID too.
Thank you.
Any other questions from board members? I have a few questions here, by the way, that Frida once sent me that I want to ask, so, but.
Sure.
Okay, so the first one is, both contracts reference that the system wishes to have contracts procured in a FEMA compliant way without having to rely on emergency actions. So can you elaborate on that, or?
Yeah, so, and I brought with me, we have James Cassidy from the finance team who works very closely with OMB, who's coming up to join me. The way this works is right now for the test and treat MOU that we have with OMB, we have been covered for 100% of the costs incurred to date. So the MOU that's how the MOU operates, and it has worked to date to have OMB be the entity that covers us. And then moving forward, we work with OMB to, as a city, get reimbursed by FEMA.
The city's the one that gets.
So yeah, we work together with OMB. So OMB has its own FEMA division. So we work together to seek reimbursement from FEMA. But for us, with test and treat at Health and Hospitals, we have an MOU with OMB that has covered us to date, and that will cover us moving forward as well.
So, so if you look back then, does this mean the emergency contracts we have entered into during COVID may be disqualified for FEMA reimbursement? Since they were procured under emergency basis and not under competitive base process?
No, and I'll let James weigh in if you want to share more there.
No, I think it's just that we're doing this to avoid doing emergency actions that would be compliant.
Do it.
This is getting ahead of it, so that we don't.
This is planning ahead.
Exactly.
Another question I got
Yeah.
here is, just to confirm that there's no requirement or promise of business to any of these vendors, especially in the case of mobile response, the first one. It's possible that there won't be much MPX work, and as it continues to decline and no new diseases emerge. So,
So the answer to that is no. There's been no commitments of any business. The reason we're doing this is to plan ahead, and that if the board today approves this resolution, it would enable us to, again, plan ahead for anything that would come up in the future. I hope that you're right, and there will be a limited need for MPV activity in the future, but it is still in the city and is still in the country. So I don't want to get ahead of ourselves there, but this enables us to plan ahead for MPV or any other infectious disease that would come up in the future.
any concerns about vendor capacity if both contracts are activated? I mean, I'm talking about contracts 3 and the next resolution that you'll talk about, because there's some overlap in vendors.
Yeah, so we've considered that, and no, we don't have any concerns about capacity. But it's a good point, and we have specifically considered that.
And then the last question I had, both contracts, for this contract and the next one, but the CEO can activate the agreement under emergency authorization. They ask OMB to cover costs, and the board is notified of activations. This is on the slide with the board request for both resolutions. So I would like to confirm that both the authorization to proceed be contingent upon OMB agreeing, not just being asked to cover full cost?
Yeah, so, and I'll let James weigh in there, but OMB, we aren't just informing them, we are asking them to confirm the cost to be covered.
That's correct, yes.
Okay.
Good
so,
question.
And on this contract, there is no parameters for costs, in the authorization. There's an estimate. There's an estimate, but nothing specific. It's not to exceed. So
Right.
there is no not to exceed. Can you clarify that, or?
Yeah, I mean, the hope is that we won't need to use this any more than is absolutely necessary. We include the estimate here as, if there is continued need, what we would expect the continued need to be. But any spending would have to be confirmed with OMB before it would go forward. So that's the communication that would and the collaboration that would need to happen ahead of time. Andy, do you want to share more?
I was just gonna say, I think this is also on the model of our emergency contract, like general contractor. Danielle, I don't know if you are here to talk about that, but we have another model of kind of in the background, flat out emergency contractor. Because we don't know what the circumstances will be. There's not an NTE there, but there's notice to the board when it's activated. It's just the uncertainty of identifying an amount.
Any other questions from board members? Feniowski?
Maybe it's not applicable to this because we're talking about 2 years and maybe a third year because you have 6 months. But I think you have achieved certain level of coordination, kind of connection with these vendors, which allow you to be very efficient in your deployment and the results. I know that your results have like 24 hours, really high and all that. But as time passes by and the volume goes down, and this vendor doesn't have an NTP, are there anything in the contract that requires at least a yearly discussion, coordination, or the vendor to tell you the readiness? Because there may be changes in the organization, different strategies or personnel movement, so that the contract is valid. It's not like you want to activate and then you figure it out that they are not ready because they move on because there is no money. Is there anything in the contract to ensure that you know that these services will be provided if requested?
Yeah, well, the contracts do require readiness as part of the contract. In terms of sort of ways to check in or fail safes there, I will phone a friend to see if Andy or anybody that's been close to the language of the contract wants to share more.
I'm sorry, I'm not, I didn't know. So there isn't specific language in the contract for you to meet with them, but as the operational owner for readiness, you would be the owner to do so. So it can be put in, but it's not typical. It's not in there today, but it can be added.
Makes sense.
Because you want to make sure that they will be ready if you need them, not to be surprised and believe you have something.
Yes, thank you, Penny.
Okay. Yes.
So I'm also a huge fan of the kind of mobile model. I think it's amazing, very brilliant. And I'm also curious about what are kind of the thing from a mental health perspective, given that there's like pandemic and then you have kind of all these infectious diseases that are coming up. Wondering whether people are accessing mental health resources in that space, and what is kind of is there a plan or thinking about how you might incorporate that into the plan?
And in terms of people, do you mean the staff members on the units or community members that we're serving, or both?
I guess both and actually, yeah.
Yeah, I think both is the right way to think about that. Yeah, I mean, we happy to take it offline with you too a little bit later, but our staff members have encountered situations that have been very stressful for them with our mobile units in the past. And we've been very quick to provide. We have Helping Healers Heal and a lot of mental health resources here within health and hospitals. But it is something we have a strong focus on because of everything we've experienced over the last 2.5 years. I mean, in fact, I would say probably anybody that's been fighting COVID with mobile units for the last 2.5 years, we should expect them to be paying attention to their own mental health. And for people that are coming to our units, I mean, a lot of our units are staffed by clinicians. So we have in the past done trauma-informed care for our teams, like in our street health outreach and wellness units, things like that. Based on sort of need, we would want to continue doing that. And the final thing, which I think goes a little bit beyond, but with the the MPV mobile units here, a lot of the units are going to places like the New York City ballroom scene, where there are places where we want to make sure that we have a lot of sensitivity to both how we culturally are approaching the situations, but also to the mental health of people that we're serving there. So I think it will be important for us to keep a focus on that moving forward as well. And I would say we've done a good job so far, but we can't let our eye off the ball. And happy to share more offline about some specifics if you like.
Okay, anything else? So let me ask for a vote then. Ann Williams Isom,
Yes.
Matthew Ziegler,
Yes.
Patricia Martone,
Yes.
Michael McRae,
Yes.
Karen San Hilaire,
Yes.
Robert Nolan,
Yes.
Benioski Peña Mora,
Yes.
Sally Hernandez Piñero,
Yes.
Anita Kawatra,
Yes.
and Jose Pagan, yes. So, resolution approved. Let's move to the next one. Thank you so much, Ted. So the next one is authorizing New York City Health and Hospitals Corporation to enter into contracts with the following 5 firms: MedRite, Rapid Reliable Testing LLC, aka DocGo, Fulgent Genetics Inc., Community UC, and Premier Assist, the vendors, to provide steady state and standby test to treat resources during a COVID-19 surge event, with each contract to have a 1-year contract period with a 1-year option to renew, and with a set of contracts that will have a not to exceed amount of $156,900,000. And this was presented to the Medical and Professional Affairs Committee on 9/12/2022. Go ahead.
Thank you. So this contract here does build off of, as Fenny was pointing out for the last one. So this is specific to COVID-19 mobile test to treat operations. The backdrop on this, just for the record, is this builds upon our mobile experience that we've had for the last 2.5 years, starting with COVID testing, its success engaging with communities by bringing it to your doorstep, COVID vaccinations after that. And then we started to think more about how could we create a one-stop shop model to really bring people everything that they would need with respect to COVID during one visit. So the way the model works is you go up to one of the mobile units, you get tested with a rapid antigen test. If that's positive, we have a clinician right there that you'll speak to. And if you're eligible, you'll walk away with a matter of minutes later with Paxlovid, a medication that in clinical trials is 89% effective, has since been proven to be effective during Omicron and could literally save your life. So building it into a one-stop experience was our way of being able to really bring equity, focused on our task force on racial inclusion and equity neighborhoods, to give you, to remove barriers for you not only getting tested, but actually getting the treatment that could save your life. In this contract, or in this proposal here, we seek to establish a baseline number of units, of which we currently have 30, and then we seek to establish a mechanism for expanding if we do see cases go up, which could be driven by a variety of factors with the weather changing. This fall, we want to make sure that we are ready and prepared ahead of time. So in the case of a surge, we would supplement and increase the number of units that we have on the street every day. This will help to avoid the need for emergency procurement and contracting, of course. So next slide. So the scope of work here, the vendor would manage the testing and would bring all of the staff along with them, which is currently how the model operates. The vendor would operate the test to treat unit with not only the clinical staff, but also, again, the dispensing of the Paxlovid medication. The vendor will provide all supplies, including PPE. The vendors will propose budgets on a per day, per team basis, and or a per test or per prescription treatment basis as well. No labor impacts, no EITS impacts, and these are not health and hospitals patients only. These are community patients. We want to make sure that we bring this resource to everybody across New York City to remove barriers. So next slide, in terms of our RFP here, 5 years in business and public health testing, experience with rapid deployment, important. Substantive criteria, 30% relevant experience, 30% thoroughness, 25% cost, and 15% MWBE. On the right-hand side, you can see our evaluation committee. On the next slide for a procurement overview, this was posted to the city record on July 15th, directly sent to 28 vendors. On August 22nd, the evaluation committee completed scoring, and the top 5 firms were selected. Next slide, please. And here we display the top 5 firms, and as well as their MWBE goals, which are 30% each. Next slide, please. So the request here is for my Office of Ambulatory Care to receive approval to award the contracts to these 5 vendors for a baseline capacity of 30 test to treat units with for the initial renewal terms totaling 2 years, and there is a not to exceed of $156.9 million. Of note, this the not to exceed would go, or the expected spending would go down if the purchasing of the therapeutic currently Paxlovid continues to be free. This is assuming that in October of 2022 it is no longer at no cost. If Paxlovid is able to be continued at no cost, the overall price estimation here would drop to $127.3 million. The contract term would be 1 year with a 1 year renewal option at the discretion of New York City Health and Hospitals. The process for activating this would be identical to the infectious disease contract. The president and CEO would have an emergency authorization to activate the agreement. OMB would be informed, agree to cover costs, and then the board would be notified of any activation, of course. Of note here, throughout this and our other proposal as well, we do all of this in lockstep together with our Medical and Professional Affairs Office, and that includes lab services and clinical input. So we would do this together as a shared health and hospitals team as well. So with that, happy to answer any questions on this as well.
Ed, I could be misremembering this, but I feel like this is the example where you had a community member that came up and she didn't have her phone and you were able to do it. Can you share that story?
Yes, thank you, Deputy Mayor. So the you said in life sometimes you just can't make up stories that are worth worth a million words. So the first patient that we had that came to our when we opened up our first mobile test to treat unit was a lady that had been exposed to somebody with COVID. She developed symptoms herself, was feeling pretty sick, but didn't have a cell phone, and she figured she didn't need to come out and get tested, because if she was positive, she'd want to call somebody for help, but she literally didn't have a cell phone, so she couldn't call anybody. When she saw a sign that said you can get tested and get the medication here, she said, okay, I'll get tested. Of course, she was positive, and it didn't matter if she had a cell phone or not, because she walked away after being tested within about 20 minutes with Paxlovid medication, which in her case could have saved her life.
Thank you. Sally Hernandez?
I want to give testimony to the fact that I had COVID. I called the hotline. They put me right through to a doc. I didn't say who I was, and got screened, got through to a doctor, and had Paxlovid the same day. Just, it works.
No, thank you, Sally. And I mean, in New York City, I have family in Los Angeles. I mean, they have trouble figuring out how to get tested, figuring out how to get Paxlovid. Here, we have a single number with 212 COVID-19, easy to remember. You'll get the medication delivered to you the same day in your home with a positive home test, or you can come to one of our mobile units. And if we support the proposal today, you're going to see more and more of them on the street, and you walk away within 20 minutes with the medication, even faster.
Fernioski Peñamora, and then Patricia Marton.
No, I will cede my.
Yeah, no, well, thank you. I just wanted to say that this is incredible. It's incredible to be able to offer this to New Yorkers, because even for someone who has access, right, who knows where to go, you can run out of the period of time that it takes that you should access Paxlovid. The period is like 5 days. Trying to get a hold of a provider, doing all of this, you might not even get to that period, and then the window closes on you. To be able to feel sick and be evaluated, do all that within 24 hours is like something that you don't really get a chance to do that easily, and we're able to offer that to New Yorkers, and that's something we should be very proud of. And I'm very proud of how not only are we just thinking about getting it done, we're thinking about how we continue to grow the plan. So to me, I think this is just something that we just have to keep doing. We've done this, and then you took it another step and you said, okay, what else can we do? We should look look to the future and look at the next steps in case something else happens. Monkeypox is out there now, other things are out there. So I think this is just really forward thinking, and I think this is awesome. Awesome. Thank you.
Completely agree. I think that's definitely very important, and I think the impact is real. I just have a question.
Yeah.
In your third bullet, no, in your fourth bullet, you said that this will be authorized by the president with OMB, but at the same time, you said that there is going to be a baseline. So are we authorizing right now 30 mobile units to continue for around 3 years? Is this? How long is this? 2 years?
Yeah, so the contract here is 1 year with a 1 year renewal, and the baseline, the OMB would, and I'll let James share more here, but they would agree to whatever spending would need to happen consistent with this contract prior to any spending happening.
So are we approving the 156.9 today, and you have the backup of OMB to backfill that money, or how much is the 30 units? What are we approving? Are we approving the expenditure of the baseline or the upper limit?
You're approving the not to exceed.
Okay.
The 30 units are a portion of that, but it also accounts for expanding with further units. So the 30 units do not cost 157 million themselves. This encompasses or incorporates a degree of not just the baseline planning, but also surge capacity if we do need to, if we do see an uptick of cases. But OMB, if we did do that beyond the baseline, would agree to, and James can agree to this, agree to prior to any spending happening in that case.
Thank you.
Anything more?
Thank you.
Thank you. So I have one question that came from Frida Wang, and it's connected to slide 3, but I'll read it here quickly. It says, in the event of a surge, additional test-only units may be activated under a separate contract to supplement these test-to-treat units. So additional test units may be activated. Is that referring to the previous contract that we approved, or something else that would come before us?
So in the event of a surge, we let me pull up the exact bullet point here. But so this is for our test to treat units. There could be a situation where we would want to have test only units, for example, PCR testing only units. We're just being thorough by listing what the different types of situations could be. And let me just pull up the bullet here. Is she referring to the bullet of
Next to the last.
in the event of a surge, additional test only units may be activated under a separate contract to supplement? Yeah. Correct. So actually, they could be activated under the infectious disease contract, because that covers COVID as an infectious disease, along with any other infectious disease that we know about now or will know about in the future.
So there won't be any emergency procurement issues, basically, because
Correct.
it's based on that. Okay.
Correct. That's the purpose of it. Yeah.
Okay.
But that contract only is for testing, or that also include the treatment?
The infectious disease contract includes testing, vaccination, and treatment.
Oh,
so
includes
it's
all.
broad for infectious diseases. This one's focused on test to treat for COVID.
Okay, anything else? So let me ask for a vote. Ann Williams Sison?
Yes.
Matthew Ziegler?
Yes.
Patricia Martone?
Yes.
Michael McRae?
Yes.
Karen Sanchez? Robert Nolan?
Yes.
Enioski Peña Mora?
Yes.
Sally Hernandez Piñeiro?
Yes.
And Anita Kawatra? Jose Pagan, yes. So thank you so much, Ted.
If I may, I just want to say thank you for your support. It makes me proud to be a New Yorker together, being able to push the envelope to protect our city. So thank you.
Thank you. Let me move to the next one.
Thank you, Mr. Chair. Item number 5, authorizing New York City Health and Hospital Corporation, the system, to sign an 18-year lease with 90-2 QB Holdings LLC, landlord, for approximately 40,000 square feet on the ground floor of 90-2 Queens Boulevard, Queens, New York, for use by New York City Health and Hospital Elmhurst, and New York City Health and Hospital Queens, for administrative office space at an initial rent of $37 rentable square feet, or $1,480,000 a year, which will escalate over the term to reach $45 rentable square feet over the final 7 years of the term, for a total base rent over the term of $28,520,000, after taking into account 1 year of free rent, provided that operating expenses escalations are payable to landlord, projected to be a total of $1,732,000 over the lease term, are not included in base rent, for a total payable to landlord over the term projected to be $30,252,004. This was presented to the Capital Committee on September 12th, and it was approved for full consideration by the board.
Thank you, Dr. Peñamora. And before we get started, let me just say Aaron Kelly is representing Deputy Mayor, the Deputy Mayor in a voting capacity. Welcome, Aaron. Go ahead.
Good afternoon, everyone. My name is Helena Arteaga Landaverde. I am the humble CEO from Elmer's, and I'm here with our CEO from Queens. And we're here to really ask for your approval for this offsite. One of our major goals of doing this work is no surprise to anyone on the board, both Queens and Elmer's, we are back to our pre-COVID numbers. We're busting at the seams. And one of the great things, well, that brings a lot of good revenue for us and a lot of good things for the community. One of the things that we have kind of holding us back a little bit is our capital projects. Currently, we have about, between both hospitals, we have about $200 million of capital work that we have to get done. In order to get that work done and executed, we need some wiggle space. We need to offshore some of our current programs and back-end administrative office to this current location, which is what we're proposing today.
Queens Hospital provides 269 beds to the community. Queens is scheduled to benefit about 44 million of the number that Helen pointed out over the next 5 years. Our projects include the N4 renovation building, which will house the peritoneal home dialysis program, the P4 building, which will house the behavioral health and primary care clinic combined, and also we will be able to establish our retail pharmacy and also create overall access to primary care services.
As you know, Elmer's Hospital, we're about 545 beds. While you think that would be enough, in reality, this new capital projects will expand that. And currently, that's about $160 million that we need to fully execute in the next 5 years. So these are the projects that it would help us really execute moving forward. Next slide. So the main goal of this new office space is to really provide an opportunity to share space with some back-end office functions. The project will really allow Queens and Elmer's to really open up space for these critical projects and clinical programs, which benefits not only each hospital, but also our community members. And also, it brings a new attractive location near to both hospitals and also sends our message to our community that we are one system. We are brother and sister organizations.
And the new office space on Queens Boulevard will accommodate 91 employees from Elmer's and 50 employees from Queens Hospital. Travel time between the facilities is about 15 to 20 minutes. The location is quite accessible to various modes of transportation, and it also includes parking. On Helton Hospital shuttle route between Elmer's and Queens Hospital, it stops every 30 minutes. And there's also, of course, the availability of the trains.
Good afternoon. I'm Leora Jontef, Assistant Vice President of Real Estate. I'm here to talk about the lease terms pretty quickly. The resolution requests a 40,000 square foot lease for an 18-year term. The landlord will perform base work and supply furniture. Our rent will commence when the work is complete. Our rent will be $37 per square foot, or $1.48 million annually, and that will escalate every 5 years by 10%. Our analysis indicates that that is fair market for office space in Queens. Annually, H&H will have some expenses. We will not have to pay real estate taxes because we will be the sole occupant of the condominium unit. We will pay electricity, and we will pay a proportionate share of our operational expense increases. And we estimate that to be 25 cents per square foot per year. Next slide, please. This is a condensed cash flow showing incremental changes from 1 to 5, year 6 to 10, 11 and 18, and that's it.
Any questions? Happy to take questions.
Yeah. I was wondering how you were going to spend all that money and keep the hospital running at the same time. And you very brilliantly thought, we'll just get more space. Very, very clever very, very fast action, obviously, because you just had got most of these appropriations. I don't know who did the negotiating, but you have very competitive market rate rent, great concessions, great backfilling. So congratulations to you.
No, and Sally, that's a very good insight. One of the things that both Neil and I and most of our colleagues know is that we work really well together. We already have programs and grants that we're doing jointly. So this is a perfect alignment of the work that we're doing just at a bigger scale. And this really opens up to even ask, I know the deputy mayor left, but even opens up to even ask for more money.
And our collaboration is we meet monthly,
Yeah.
the two of us, to talk about how we can collaborate and improve on programs for the Queens communities.
That's great.
I want to follow up on Sally's point, and I think, having been in the city, I know how difficult it is to plan for capital programs, particularly the issue of swing space. And I think you are getting ahead of that, creating the swing space so that you can do and realize your capital program. So thank you for thinking ahead. And it's not bad to go and ask for more money.
Any other questions or comments? Okay, so let me then ask for a vote. Erin Kelly,
Yes.
Matthew Ziegler,
Yes.
Patricia Martone,
Yes.
Michael McRae,
Yes.
Karen Saint-Hilaire,
Yes.
yes. Fenioski Peñamora,
Yes.
Sally Hernandez Piñero,
Yes.
Anita Kawatra,
Yes.
and Jose Pagan, yes. Thank you so much.
Now I'm reading item number 6,
Yeah.
authorizing New York City Health and Hospital Corporation, the system, to execute a contract with Carefree Improvements, the contractor, to provide construction services in connection with the repurposing of space on the 7th floor of New York City Health and Hospital Metropolitan Hospital Center, Metropolitan, to create a system-wide contact center for the duration of the proposed construction project for an amount including a 10% contingency of $624,454, not to exceed $6,869,000. This was presented to the Capital Committee on 9/12/2022 and was approved for full discussion by the board.
Thank you, Penioski, and the rest of the board. Good afternoon. We're here to request to enter into contract with Carefree. With me today is Tamika Campbell, my Director of Capital at Metropolitan, and Juan Masrapid, the lead for the program. So they will be presenting today. Thank you.
Hello, everyone. Good afternoon. Just to give a little background in regards to the project, this is the third phase of the renovation for the contact center. And this phase is located on the 7th floor behavioral health building of Metropolitan Hospital. The renovations will include centralized HVAC system, which will provide cooling and heating, new LED light fixtures, new security system and cameras, and also new IDF closets to support the new layout and head count. And the space is approximately 18,000 square feet. Next slide, please. Just for the first bullet of the future state, the space will have approximately 252 stations, 12 offices, 1 staff lounge, 4 huddle rooms, ADA compliant restrooms, and staff lockers.
This is space that we're going to be sharing with our colleagues from Revenue Cycle. It's going to allow us to expand our electronic specialty referral program. It will grow our internal contact center unit that will allow us to reduce our dependency on our contractors. It will keep up with a multi-year growth cost reduction plan, which will require space to accommodate contact center staff, onboarding, new and ongoing training, and new patient organization initiative for both on-site and remote work, and will provide multi-use working stations, which basically allow any agent to come in with a laptop, plug in, and work from there.
Next slide, please. This is the main slide that we're here for. So this is Carefree's contract. It shows that there's a breakdown of funding sources. There's two funding sources. We have our CFRP grant and our NYC capital dollars. And those dollars total $6.869 million with a 10% contingency. Next slide, please. This gives a little bit more detail in regards to the overall project budget. Our state grant funding source currently requires for the project to be completed in March 2023. So the breakdown of the two funding sources, which totals at 13.259 mil, also incorporates make-ready work that was required for the site, and those categories cover design, construction, outfitting, and our 10% construction contingency for the project. Next slide, please. This slide just basically gives a little bit more detail of the breakdown for the construction. It shows Carefree's contract broken down between the two funding sources and also the make-ready work, which incorporates JOCs and consultant contracts that were utilized. We needed to move ahead utilizing JOCs and consultant contracts because of the time-sensitive nature of the CRFP grant, which we have a deadline of March 2023 for completion. Next slide, please. This is the procurement of the process, which we had 26 vendors. Okay. Next slide, please. This is our construction contract that shows Carefree's dollar amount being at 6.2 mil. They're currently a JOCs contractor with us with an 84% satisfaction rating. And this project is expected to begin the fall 2022 and completed spring 2023. Thank you.
Any questions on?
Sorry, I actually have a macro question and then a question about this contract specifically. Looking at the work that's being done at Metropolitan, Bellevue, and which the other hospital is Cumberland, and in total, how much is being spent, including the state funds that are part of this?
The total that is being spent, including the state funds,
Yes.
is 15 mil, including you said Cumberland and Bellevue?
Yes, how much altogether?
$15 million.
50?
15
million.
15?
I'm
1
sorry.
5.
Yes.
I was just wondering, at some point, it might be helpful to get a sense of our contact center operations, because they're massive. And we have a number we can call that's supposed to like direct us through everything, and that works when it works well. But I don't know if these services are like, I know they're new services we're providing in terms of giving patients actual appointments and then calling and reminding them they have appointments. So are these little centers now, not so little centers, being created now to house these new services? Is there some kind of more strategic thought as to how they fit into our overall contact center operations? It just would be helpful, I think, Mr. Chairman, to at a point have a better sense of how the customer service operations works and how this fits in.
You wanna?
Happy to take that. I think it's a great discussion. It's a critical part of access to our system. I think, rationalizing, standardizing, and physically consolidating some of the various call centers we've had is definitely a strategic priority. It's important for access. You heard mention of the revenue cycle teams being housed with them. It's a critical part of getting people insured and helping people enroll in coverage. So there's a lot of good things to talk about. I think it's a great discussion for the board, either at the committee level or the full board level going forward.
Thank you.
Yeah, we should plan some activity around that, because I was thinking about how, whether it's an educational session or something like that, but as you expand the capacity on this one, are you adding that much volume of capacity when it comes to making calls and contacting patients, or is it substituting something we already offer but not internally? And also what is included in that mix of services and how that's handled, just to get a better sense of how that works, will be incredibly useful. So any questions or comments on? Okay, so I'm gonna keep moving because I have two more resolutions, so. Erin Kelly,
Yes.
Matthew Ziegler,
Yes.
Patricia Marton,
Yes.
Michael McRae,
Yes.
Karen St. Hilaire,
Yes.
Robert Nolan,
Yes.
Inioski Peña Mora,
Yes.
Sally Hernandez Piñero,
Yes.
Anita Kawatra,
Yes.
and Jose Pagan, yes. Thank you so much.
Thank you.
Thank you. Mr. Chair, I will be reading for the record both item number 7 and number 8, both of those resolution, but they will be voted separately.
Thank you.
So it's going to be a long reading, but authorizing New York City Health and Hospital Corporation, the system, to execute a standby job order contracts with each of EIA Electric Incorporated, EIA, Genco Electrical Contractors, Genco, and Mac Fiancali and Sons, MCF, to provide electrical construction services, each for an amount not to exceed $8 million and each for a term of 2 years. This one was presented at the Capital Committee on the 12th of September and was approved for full discussion by the board. Number 8, authorizing New York City Health and Hospital Corporation, the system, to execute standby job order contracts with each of AWL Industries, AWL, Volmar Construction Incorporated, Volmar, and WDF Incorporated, WDF, to provide HVAC construction services, each for an amount not to exceed $8 million and each for a term of 2 years. This also was presented at the Capital Committee on the September 12th of 2022 and was approved for full discussion by the board.
Thank you. I am Manny Saez from the Office of Facilities Development, and as I previously mentioned, this will be a joint presentation for job order contracts for our electrical services and our HVAC services. And with that, I'd like to hand that off to Mr. Menji Indar.
Mahendranath Indar, Assistant Vice President, OFD. So job order contracts are construction contracts for specific services that we procure with an NTE and the facilities access via work orders when they have an idea of what the scope of work they're pursuing. Currently, we have electrical and mechanical HVAC contracts that were awarded in 2020, and prior to expiring in July 31st, or on July 31st of this year, we came to the board in CRC and they were extended by 6 months to allow us enough time to complete the current procurement that we're in. Next slide, please. This is the current HVAC vendors that we have. We had 2 vendors. One vendor dropped out. We were left with just Vastec. For the $6 million they were awarded, we utilized a little over $1 million. We had $4.9 million remaining. Next slide. This is the current electrical pool. We have Gemco and Mac & Sons. Both were awarded $6 million contracts. Gemco, we utilized a little under $4 million, and Mac & Sons about $2.6 million. We use Gemco mainly for the point-click care, which is the long-term care EMR, and we use Mac & Sons to do make-ready work for Epic, which is our acute care EMR in Gotham. Next slide. This is the procurement for the 3 HVAC contracts. We had 3 separate bids that each were opened separately on June 7th, 8th, and 9th for 3 contracts, each $8 million over a 2-year term. The first bid was won by WDF, the second by Volmar, and the third by AWL. Next slide. Similarly, this is the procurement for the electrical contracts. They were also opened on June 7th, 8th, and 9th. We also awarded 3 contracts for $8 million each over a 2-year term. Gemco was the first successful bidder. Mac & Sons was the second, and EIA was the third. Next slide. These are just the vendor evaluations for Gemco, Mac & Sons, and Volmar. They have current contracts with us, and Gemco received a good overall, Mac & Sons an excellent, and Volmar are wrapping up projects right now, so we do not currently have an evaluation for them, but those evaluations will be collected when those projects are complete. Next slide. This is the utilization plan for the MWB utilization plan for the HVAC contracts. For all 3 contracts, there's at least a 30% utilization plan in place. Next slide. This is the MWB utilization plan for the electrical contractors. 2 of the 3 are MWB certified, therefore 100% of the spend on those contracts will count towards MWB utilization. The third, Gemco, has a 30.25% plan. And the last slide is just the resolutions, and happy to take any questions at this time.
Questions on this one? Okay, so let me then ask for a vote. Erin Kelly,
Yes.
Matthew Ziegler,
Yes.
Patricia Martone,
Yes.
Michael McCray,
Yes.
Karen St. Hilaire,
Yes.
Robert Nolan.
Can I ask a question? Will any of these funds be used for active projects under consideration right now and under construction?
So, no, typically, these are not to exceed contracts with a not to exceed amount that it's for future work.
Okay,
Also, the value of the work.
Conceivably, then, we could have a year or 2 or 3 years ago voted money for projects that are under construction now, improvement projects at various hospitals across the city.
Correct,
Your
yes.
father.
Once you
Okay.
approve these contracts, yes.
Okay,
From
thank
that
you.
time until they expire is
Yeah,
work.
I vote aye.
Thank you. Fenioski Peñamora,
Yes.
Sally Hernandez Piñeiro,
Yes.
and Anita Kawatra.
Yes.
I should have said that that's for item number 7, so for item number 8, let me do that again. Item
Okay.
number 8 now. Erin Kelly,
Yes.
Matthew Ziegler,
Yes.
Patricia Martone,
Yes.
Michael McCray,
Yes.
Karen St. Hilaire,
Yes.
Robert Nolan,
Yes.
Fenioski Peñamora,
Yes.
Sally Hernandez Piñeiro, and Anita Kawatra.
Yes.
Thank you so much. So let me move on to.
Thank you.
Thank you. Item number 9, adopting the attached mission statement, performance measures, and additional information to be submitted on behalf of New York City Health and Hospitals Corporation for fiscal year 2022 to Office of the State Comptroller's Authorities Budget Office, the ABO, as required by the Public Authorities Reform Act of 2009. This was presented directly to the board. This is being presented directly to the board on 9/29/22 today.
I'm happy
Yeah.
to speak to it.
Yes.
So the Public Authorities Reform Act, as board members know, is an important part of what governs us as a public benefit corporation in the state. And each year we submit our mission statement, some background on the board of directors and questions that you all look at and address, and then some of our key performance indicators and the metrics that we track as a board. So in the materials here, we have the executive summary, our mission statement in full, which is, in the interest of time, I won't read, even though it is just a wonderful, wonderful thing to be a part of, and the answers to the questions that that have been brought forward and that you all have looked at. And finally, we have the system performance dashboard that we track in the strategic committee under Dr. Peñamora's leadership. We have the description of the different measures and the results as of the most recent quarter that we reviewed. As a reminder, the categories of measures that we look at are under quality and outcomes of our clinical care. They're on the care experience for our patients. There are our financial sustainability, access to care, and then the culture of safety for our patients and staff. We also track measures tied to racial and social equity, a key part of our mission and values, and then our COVID-19 response. So I'm happy to take any questions on these measures or the act in general, but thank you all for your support and for continuing this important project.
Thank you. Any questions? Okay, so let me ask for a vote then. Erin Kelly,
Yes.
Matthew Ziegler,
Yes.
Patricia Martone,
Yes.
Michael McCray,
Yes.
Karen St. Hilaire,
Yes.
Robert Nolan,
Yes.
Fenioski Peñamora,
Yes.
Sally Hernandez Piñeiro,
Yes.
Anita Kawatra,
Yes.
and Jose Pagan, yes. Thank you so much. So let me keep moving. Let's go now to an informational item connected to the fiscal year 2022 annual public meeting responses. Deb?
Hi, everyone. Very, very, truly nice to see you all in person. For those of you who don't know me, I'm Deborah Brown. I'm the Senior Vice President for External and Regulatory Affairs here. I'm joined by my colleague, Okenfe Labarte, who is our Senior Director for Community Affairs. This is a recap that we do annually. You might remember it from years past. We are lucky enough to have our 5 annual public meetings every year. And if you go, thank you, we are commemorating here the dates and how they were conducted. What we do in this presentation, real quick, is to give an overview of the comments that were taken and the responses. And what happens, just so you know in real time, is our team attends all of the public meetings, goes through the transcripts, identifies the comments, and then afterwards does the painstaking job of going back to each of the facilities to make sure there is a response to each of those questions. Those of you who attend the public meetings know that it is an excellent opportunity to hear public comments, but it is not the forum for the kind of exchange and responses. So then if you can go to the next slide. So what we do, as I said, is we compile and we go through and make sure there is a response for everything. What I am showing you today is just, kind of the summary overview. And then this entire deck has every single comment that is taken and the response to it that is posted publicly on the URL that's included in the 4th bullet. And of course, I'm happy to answer any questions, now or otherwise about these. And again, this will look sort of familiar to you because we've done this the last several years. So the sort of big groupings here in blue, what we do is we go through and we try to sort of find commonality for what the public comments are. We sort of did slightly bigger swings this year, and I'll talk about that in a second. So, the largest is healthcare funding disparities and inequities. Probably not surprising given the last 2 years that we have been through. This is somewhat similar to the responses in the community health needs assessment, in which, I think our community members are really aware of perhaps some of the larger issues surrounding community health. We saw that in the community health needs assessment. We see it here. There's a lot of questions about specific facility projects and funding. Either the status of them, whether things have been funded, sort of where particular projects are. Questions, of course, about COVID-19 vaccinations, access to vaccinations, availability of them. And remember that if you look at the schedule, some of the questions that are asked are at this point, 5-6 months old. So at the time there might have been questions asked that, either answered or became moot. But of course we go through and answer every one of them. Public safety, that's another example. This is something that came up in the community health needs assessment that is not about healthcare specifically, but it is on the minds of people, of the communities we serve, and it is our obligation to hear and to respond. And then staff resources, what is available for, our wonderful team members, what is available for their training, etc. And so something that we did this year, just to try to keep track of it all, if you can go to the next slide, we sort of coded each of the questions within these particular topic areas. The breakdown is by the location in which they are asked. And so you can sort of see we kind of married some of these together into those 5 big blue buckets on the preceding page. But we tried, I wanted, the team to try to get to slightly more quantifiable. So ideally, this is something now we'll be able to track year after year to see how kind of questions and comments go up and down depending on the year. And so that's the overview. I'm happy to answer any questions.
Go ahead, Sally.
Just, Deb, really a terrific job. It's both consolidation, so you get a really nice perspective of kind of cutting across the board issues, but also a very deep penetration into what individual people are thinking about us, have questions about us, and if just reading through it, it's like a little encyclopedia. You just get tons of information across the board that you don't always get in another forum. So it's a lot, but it's really highly informative. Very good job.
Great, well, thank you. And I want to commend Ken Fay and also Rachel Larkin and Iman Musani, who are our team, who did a lot of the heavy lifting. Did I get everyone?
Yep. Go ahead, Robert.
I would also like to express my appreciation to you and to Okemfe for a job really well done. As you know from my years on the board, I've seen many iterations of reports after the hearings. Some come out 6 months later, 7 months later. While hearing it, I believe, in March, April, and May, we may have stuck in the June meeting, but it was around that time. For you to be able to turn around a document like that, like this, in the detail that you have, especially with the breakdown at the front, which highlights some of the major areas of concern, is quite an accomplishment. We've come a long way. This is not your first time doing this. You did this, I think, last year too. But when that work is done, it's done professionally, I think it's our responsibility to say thank you. Thank you for making us look good, and thank you for responding to those folks who asked questions back in March and are wondering, were they listening to me? We were listening, and this document, which I'm sure is on the website at this point, okay, they'll have a chance and opportunity to get that. Thank you very much.
I had a quick comment or question, and I agree totally with everything that Robert said. What happens, so you get the answers, right, from different hospitals in the system when these questions come up. Can you comment on the process on following up with after that answer is provided? And because some of them are very specific, but some of them are very broad, like I want to, an ED in my community or a new hospital or.
Yeah, no, it's a great question. I think frankly, very few of the things that come to public meetings are shocking to us or news to us. Typically, and this is to their credit, the people who are engaged enough to come to public meetings are often people who are on the CAB, are on the community board, are sort of known stakeholders, and that's in large part because of the great job that the board office and Akenfe and our team do in trying to reach out to people to get participation. So I think some of it is, as I said, questions that might have been moot over time. I think we saw that particularly in COVID. Some of it is questions that they're already in an engagement with either the facility or central office via the CAB function about. Some of them are things we picked up in the community health needs assessment also. I don't know, do you have anything else?
No, I think you've answered. One of the things we try to do, though, is if we get additional comment or response, we're able to point people to where the deck is
Yeah.
so they can find the answers.
Yeah.
Any other comments or? Okay, thank you so much
Thank you.
For your presentation and all the work you do and answering all the questions that came from these meetings. And it'll be interesting to see next year. Will be fully in person, right? So.
I've been very kind of nerdy about we need to get our codes. But I am really curious to see how it.
Looking forward to it. So for committee and subsidiary reports, the committee and subsidiary reports were emailed to you and are in your folders for your review and submission into the record. Is there any old or new business to come before this board? Hearing none, then the meeting is adjourned. Thank you so much.
Thank you.
Wow, very good. We finished early. That's good. Leave this here, throw this out.
This meeting is no longer being
We gonna go to the
recorded.
office?
Yeah.